On behalf of the Centers of Medicare and Medicaid Services, the Administration of Community Living, and the Indian Health Service, I would like to welcome everyone to the Long-Term Services and Supports webinar series. My name is Julie Cahoon, and I work for Kaufman and Associates. I will be the moderator for today's webinar. Before we begin, I'd like to highlight the main features of your webinar interface. First is the main window where you can see the PowerPoint slides. To the bottom right of the window is the Q&A pod. You can enter a question for our presenters at any time in the Q&A pod. However, today's question and answer period will be at the end of the presentation. Just above the Q&A pod is a files pod where you can download a copy of a Tribal Nursing Home's Financial Sustainability handout. To download, click on the file name to highlight it, and then click on the Download button. Please note that hyperlinks shared on the presentation slides are live and clickable. If you click on a link from a presentation slide, a browser window will automatically open. To return to the webinar, minimize the browser window. If you need technical assistance during the webinar, please enter your tech support question in the Q&A box. Our technical support staff will be monitoring these questions throughout the webinar and will work to answer your tech support questions right away. You'll receive an answer in the Q&A pod. Finally, please be aware that today's webinar is being recorded and that the recording will be made available online in the near future on the Tribal LTSS Training and Technical Assistance Center on CMS.gov. With those announcements made, I'd like to welcome everyone to today's webinar. Today's webinar is titled Tribal Nursing Homes Financial Sustainability. Today, we'll have a panel discussion facilitated by Debbie Dijak. Debbie has served as the Education Coordinator at the Archie Hendricks Senior Skilled Nursing Facility on the Tohono O'odham Nation since 2011. She has been an adjunct faculty member with the Arizona Geriatric Education Center and the Geriatric Workforce Enhancement Program. Since 2015, Debbie has been an integral leader for the Uniting Nursing Homes and Tribal Excellence Group. Val Crail has been the administrator of the Manilac Association Nursing Home for the past 6 years and has over 30 years of experience as a successful long-term care administrator. He currently is working on getting COIL approved for long-term care facilities. Rick Richards is the Chief Operations Officer for the Archie Hendricks Senior Skilled Nursing Facility on the Tohono O'odham Nation. He has worked in long-term care as a nursing home, hospice, home health, Medicaid waiver home care, and PACE director for over 25 years. 20 of those years were with the Cherokee Nation. Tammy Reed was born and raised on the Wind River Reservation in Wyoming. Her reservation is the home of the Eastern Shoshone and Northern Arapaho tribes. She is a lifelong rancher and former elementary educator, coach, and human resource director for the Eastern Shoshone Tribal Health Program. She currently serves as the nursing home administrator for Morningstar Care Center, which is owned by the Eastern Shoshone tribe. Ron Ross serves as the president of Native American Health Management, which helps tribal organizations achieve building long-term care nursing facilities since 2012. He has 25 years of experience supporting the needs of elderly individuals through the Rural Health Development, a company assisting with the navigation of financial and regulatory challenges facing the nursing home industry. I'd like to thank you all for taking the time to join us today. I will now turn it over to Debbie for an introduction to today's topic.
Good morning, everyone. This is Debbie Dijak. We're so pleased that you're on today's webinar. Our learning objectives are to give you some examples of ways that tribal nursing homes are reimbursed, some pathways. We're going to talk about steps to improve financial reimbursement and talk about engagement with tribal leadership and community members in the goal of financial sustainability. There are also some unique differences in operations of tribal nursing homes, and we will be discussing that in today's webinar. I'd like to talk about UNITE very briefly. UNITE stands for Uniting Nursing Homes in Tribal Excellence. This is a collaborative of tribal nursing homes across Indian country. We work on establishing best practices for tribal nursing homes. We build national relationships with stakeholders, and that includes our QIOs, our quality improvement organizations, our ombudsman. We work with CMS, Indian Health Service, and the Administration for Community Living, and also the geriatric workforce enhancement programs in some of the universities, including the University of Arizona and the Anchorage Native Tribal Health Consortium. We do promote opportunities to network among tribal nursing homes. We support evidence-based education, collaborate on quality improvement initiatives, and work to be culturally responsive and provide exceptional care for tribal elders throughout Indian country. We work closely with the Long-Term Support Services Technical Assistance Center, which is available to you on cms.gov, and the directions for getting there are the links below. We also have a separate website that you'll see there, tribalnursinghomes.weebly.com. All of our monthly calls are recorded, and we also have a directory of tribal nursing homes. We currently represent 13 states, and our email listserv is over 70 different members for our collaborative right now. There is a directory of tribal nursing homes on cms.gov. And we also have a quarterly best practice report where we interview some of our Unite members to get their best practices on traditional foods, topics such as emergency preparedness and cultural sensitivity or cultural humility. All of our webinars that we've done are recorded and available on cms.gov. So we hope that you will contact us or look on cms.gov at all those resources. The first slide has to do with services that are being provided by our tribal nursing homes. And so I'm going to call on each of our panelists to kind of give an overview of their facility, where they are, and what services they provide to help give us an understanding of why financial sustainability is so important, why it's even an issue. And so I'd like to call on our first panelist, Val Creel.
Hi, good morning. My name is Val Creel, and I'm the administrator of Utukana Inat Nursing Home, which is here 35 miles above the Arctic Circle. And we provide pretty basic services in our facility, such as ADL systems, the therapies. We do provide physical therapy. We don't have occupational therapy, and that is very difficult to find up in this area. If we provide a speech therapist, we actually have to fly them in from Anchorage, which is 540 miles away. And the other services, such as restorative, we provide medication management skills. But we also provide tribal medicine and dementia care and support for families. And in comparison to other facilities in the lower 48, we are limited a little bit in terms of the staff and the lack of partners. For example, up in this part of the world, there is no dialysis, there is no hospice, and if we get a complex patient for referral, a lot of times we actually have to sit down with a hospital to sit down and talk with them to see if they can provide services, because we do partner with them, and if that patient may need suctioning, for example, it's one thing we can take care of, but if they can't take care of them, then we actually have to decline the patient. So the services we are providing are pretty basic. Tribal medicine is a little bit unique here, and they work hand in hand with the regular physicians. And because of the staffing, community is only 3,500 people. Certain services we are limited on.
All right. Thank you very much, Val. Rick, would you like to talk on this topic?
Sure. Thank you. Hi, this is Rick Richards with Archie Hendricks. We're about 50 miles north of the Mexican border, so we go from one side of the country to the other. We're pretty much almost a full-service skilled nursing facility, in that we do provide the nurse aid assistance of eating, bathing, dressing, so forth. We're very fortunate that we do have both physical and occupational therapy services available. One of the things that we're able to do with our occupational physical therapist is we also provide outpatient services to our community. So Since we're located 50 miles from the nearest city that has other services, it's really a great service for our community members to be able to come in and get their therapy here. We also do restorative nursing services such as walk to dine, range of motion, that type of thing. Transportation is a big issue for us in that Tucson, our main acute care centers are a 2-hour drive from us, and most of our specialty visits for our residents are there in Tucson. So we typically travel about 6,000 miles a month, just in providing transportation for our residents to those services. We are fortunate to have dialysis and sales, which is a 30-mile trip for us, and so we do that also. Our biggest challenge for the transportation is escort services, using CNAs to go with the drivers in case the residents need some attendance there. We're very fortunate in our skilled care area and medication management. We do have RNs around the clock here, which is a great service for us since we're so far from any hospitals. I think the other things I want to mention that aren't on the slide is dietary and our activity services. Both those services help us really focus on our cultural support and cultural activities for our residents. For instance, in dietary, we have a food service group that are made up of residents who meet with our dietitians monthly to make suggestions on the menus. And then in cultural, we have a cultural representative that helps us with medicine men and different cultural activities here in the center. So both of those are really good support services for our residents.
Okay, thank you. I appreciate that. Tammy, would you like to comment on this slide?
Yes. Welcome. My name is Tammy Reed. I am from the Wind River Reservation. I am the administrator for Morningstar Care Center, which is owned by the Eastern Shoshone Tribe. Our reservation, we share with the Northern Arapaho Tribe. Our nursing home is open to everyone, and we do serve the elders from both tribes. We are a full-skilled nursing facility. We have physical therapy in-house, but we have to outsource occupational and speech therapy. Now, we're luckier than my friends that just mentioned being close to Mexico or the Arctic Circle, but we still have the logistics of travel as well. Our closest border town that provides a majority of our services is about 15 miles away. Another border town that provides services is about 30 miles away. Because we have elders that utilize doctors and services not only on the reservation but off of the reservation, we have 2 full-time CNA transport drivers that start at 8 in the morning and they transport back-to-back all day long. So it still is a bit of logistics for us. We try to focus on our culture. We do bring in a lot of community members who are more than willing to help us do different programs. We try to get our elders out in the community every day, whether it's horse therapy, to the mountains, to pick berries, just anything that we can do that is healthy and good for our elders, and so that they're happy. We are the first Eden registered Native American nursing home in the United States, and we are trying to have people look at our nursing home more as you are coming to an apartment, not that you're coming to a nursing home. And so changing this atmosphere has been really a wonderful journey.
Thank you. I appreciate that. Ron, last but not least.
Thank you, Deb. This is Ron Ross. I'm president of Native American Health Management, and we actually got our roots helping non-Native nursing homes back in 1990. And I've been in the business for 37 years helping elders. we manage two facilities, one for the Oglala Sioux Tribe, and they're on the Pine Ridge Reservation, and then the Rosebud Sioux Tribe. Now, what's unique about both of those facilities, neither one is Medicare skilled. So we do not have physical or occupational or speech therapy, but we do have a robust restorative service by RNs, and then we actually have some physical therapists that helps out with that. But we're just Medicaid certified. Do the normal things like the rest of the panelists have talked about. We too have lots of transportation issues. We work with both of the IHS hospitals. There's one on Pine Ridge and there's one at Rosebud. For the most our elders will go there, but then we do transport them to other hospitals, and sometimes that can be quite a ways away. And we're, like Tammy just said, try to make sure that the activities and the programs are relevant. We also take any federally recognized tribal members, so they don't have to be a tribal member of that specific reservation. And we'll be talking later on about the nuances in order to pay for these services. But that's what I would have at this time.
Okay, thank you very much, Ron. Thank you to all our panelists for sharing that information. We're going to move on now and talk about the expenses that are related to the operations that they just mentioned. And any or all of our panelists might touch on different ones of these bulleted items. So I'm going to go back to Val Creel.
All right, thank you, Debbie. I want to touch on budget items and go through census and staffing. One of the things that we try to do, that I've done here as an administrator, is work with the board in educating them on the whole budget process. This facility is only about not quite 7 years old. So this is the first facility they've ever seen or ever had to do a budget with. And some facilities, for example, we're straight Medicaid facilities, will do a PPD budget. Here, this facility chooses not to. So when we work with budgets, the primary expense, like all facilities, is going to be labor. But we also we educate the board on what we would consider as in hidden costs. For example, when we talked about regulations, in 2016, the Federal Register, they anticipated that the average cost of the new regulations was $62,000 this year, $55,000 next year. So we try to educate the board that sometimes your budget is a best guess. You do the best you can with it, and you work with those things. In terms of the census, we also work with them on trying to anticipate census. Years ago, this facility patients came from here from an assisted living facility, and they came over here, and over the past 5 years, you can see the population change. So the question is, once that happens, then where will you get your new referrals? So how do you budget? How do you anticipate your patient mix coming from the community? And for a small facility like this, we're only 3,500. It's difficult sometimes to do an accurate projection. You look at other villages, try to see what they do. And again, you do a best guess with it. And because of the location, again, the community just doesn't have enough staff to provide for the facility or the hospital that's here in the community. So we do use agency staff, and those are huge expenses where you have to fly somebody up from different parts of the country and provide care. But we do that so that we can take care of the elders, and that they're well taken care of. The board here is very supportive with not only medical care, but they also look at providing quality of care. So when we do staffing, it's a little different. We have 18 elders. We have 2 shifts. And they will budget actually 4 CNAs for the day shift and then 3 CNAs for the night, because what they tell the facility is that it's not enough to provide care. We want you to engage with them. So a lot of effort to the budget. This is something very important to the board. So that's an additional expense that you may not see in another facility. But that is how the board has set up our operations up here.
Okay, thank you, Val. Rick Richards?
Yes, thank you. Kind of focus on staffing a little bit. Archie's approach has been a little unique in that, as I said, Archie Hendricks is about 50 miles from the nearest city. So about half of our staff, and mostly in the nurse aid and skilled nursing and skilled areas, live an hour or more away from the center. And many of those staff members take advantage of our apartments that we have set up here for them, where they can come and stay between their shifts in an overnight dorm type setting and then return home after they've worked 2 or 3 or 4 days. So that has an expense to it. The other expense we really struggle and wrestle with at the moment is recruitment, because we are outside of Tucson about 2 hours, and then Phoenix to the north about 2 hours. We're having to recruit from those urban areas, and all those expenses related to that recruitment is substantial for us, and that turnover has its cost. So from that perspective, we're always working on ways to work with our staff and work to reduce turnover. The other thing unique, I think, to Archie Hendricks is most of our referrals or admissions come from the hospital in Tucson or in Casa Grande from us. And so we have for a small facility, have a fairly high admission rate of about 10 to 12 per month and discharge rate of about 9 to 10 a month. So that type of rotation on a small staff creates an expense also. And lastly, I guess the main thing is, as you look at your budgetary items, is really look at each department in your facility. Every department, from dietary to housekeeping to nursing to activities, will have its own unique need for staffing ratios and also training and retention. So in my mind, the key to successful financial operations from expense point of view is having a good and well-trained and stable staff.
Okay, thank you very much, Rick. Good information. We're going to also ask Tammy Reed to comment on this topic.
Well, I think I have to agree with everything that everyone said. The recruitment is difficult in these rural areas for all of us, I think. And there is a CNA and nursing shortage out there that we're all aware of, and that makes our job even more difficult. We also try to add extra staff, extra CNAs, and extra nurses just because we too want that quality care. And finding the CNAs and nurses has been our greatest challenge, I think, in budgeting. We also have a problem with people that are not educated about the reservation, and they actually are afraid to come out here to work. And so part of our recruitment has to be in educating people from off of the reservation that we are a real nursing home, and it is a good place to be. We have part of our budget issue has been our building is very old and needed a lot of repairs. So one of the things that we had to also look at was capital improvements. And so we've tried to put a great deal aside so that we can do that. I think the wages are the other consideration, so that we usually have to pay a little bit more to get people to come and work on the reservation versus working in local towns. We have tried a new approach as well, and that is hiring international nurses rather than the agency staff, because they'll be here a longer period of time. So we're finding that they cost a little bit more initially, but we have them for 3 years, so we have better continuity. And I think the other thing is just to continue to recruit on our census, and that's a huge cost in your marketing budget. But I think it's important because we too on the reservation have a limited population mix, and so we have to keep an open mind on marketing for everyone. Thank you.
All right, thank you, Tammy. Ron, Ross, would you like to comment on this topic?
Sure. To start with, on the budgetary items, it's like putting this business plan together. And as Rick said, you've got all the departments, housekeeping, laundry, maintenance, nursing, everything. So taking a look at each of those items so that when you're putting your business plan together, you can see the different line items that you're going to have to talk about. And if you have any concerns or anything, you can talk to any of us, and that information will be later. On the census, one of the things that we discovered was if you're on Medicaid and your Social Security has to go towards your share of cost, so many times our elders are, their Social Security check is putting food on the table at home, and so the kids and grandkids and possibly grandkids, and so they're reluctant to come into the nursing home because they have to turn over their Social Security, and that can affect, and it did affect us more with the Okalala facility than we first thought it would. It comes around, and then sometimes the tribal court will get involved, and some of our admissions have come through the court system. As far as staffing, that was one of the bright sides. For nurse aides, we have a college, and we have such an unemployment rate on the reservation that it really does your heart good that you can provide good jobs for folks, and they can take care of their relatives, and whether it's housekeeping or dietary or nurse aides. The professional staffs, the LPNs, RNs, are a little bit more difficult for us to recruit off reservation because we're competing against IHS, and many times we'll get an RN that'll come work for us, and then perhaps they'll decide that working at the nursing home is a little bit more difficult, and they might go back, or then they might come forward. So it just depends on the individuals. Wages, we are competitive. We know what the market is. IHS is probably one of our bigger competitors, but our wages and benefits are in line, if not a little bit better. And we really don't like to use pooled agencies because of the markup that they use, but sometimes we're forced to. We have started bringing in the international nurses, like Tammy was saying. We found them to be a godsend, and it's helped. We have two buildings. One is brand new, and so your cost there is just the depreciation and the interest, and that's expensive. And then we have an old building for one of the other reservations, and we're forever trying to Band-Aid that thing together. And they're trying to find ways to build a new nursing home. And when we get into reimbursement issues here in a little bit, we'll be able to explain a little bit why we think it's going to be possible to build a new building.
Excellent. Thank you, Ron, for that information. I'm going to forward now to the next slide, and we're going to have each of our panelists also comment on this. So we've discussed the different services and what some of the budgetary expenses are. Now we're going to look at sources of revenue and how we actually put this together and make it happen. So I'm going to go back to Val Crail to comment on some of these bulleted items.
Okay, thanks, Debbie. Here, we're at Utukanaina, we actually just have one source of revenue here, and that is a Medicaid reimbursement. Alaska's a little different, especially tribal with Medicaid, in the sense it actually reimburses higher than Medicare. And in the lower 48, it's just the opposite. But here, because our Medicaid is 100% federally funded, the rate is a little different. So they have adjusted their rate, so our Medicaid rate for us is our reimbursement system. And it's been very helpful, and it does recognize the cost of providing care here in terms of all the expenses that we run into, for example, just shipping. For every dollar an item costs, it costs us almost $1 just to ship it here. So here in this part of tribal Alaska, it is strictly Medicaid reimbursement.
Okay. All right. Thank you very much. Rick, would you like to talk a little bit about the sources of revenue?
Sure. On the Autumn Reservation, Archie's current sources of revenue mainly are Medicare and Medicaid. About 10% of our overall revenue is Medicare reimbursed. Our average drug rate for a Medicare patient generated through the MDS system is about $350 per day. Because we are able to provide the therapy services, the OT and PT, that really helps that reimbursement rate out. The Medicaid reimbursement varies. We get the state rate here for Medicaid, and right now our reimbursement rate averages about $175 a day for long-term care stays. We're not involved in the Money Follows the Person initiative or hospice reimbursement at the moment. We are exploring some long-term services and sports funding. Maybe at another time I can share that with you. And we do get travel subsidies to assist us in our operations. So the main bulk of our funding is Medicare and Medicaid and travel subsidies. We get very little from private city insurance and very little from private pay, but we do get some reimbursement in that area. And that pretty much completes our list, Debbie.
All right. Thank you very much, Rick. Tammy, do you want to comment on some of how this works at your facility?
Certainly. We are a Medicare and Medicaid facility. However, we do have an issue when we try to collect Medicare because we don't have OT and speech in-house, so it costs us more to provide that service. We also have a problem if people refuse to have their PT that day, even if you ask them 10 times or try any which way you can. If they refuse, then obviously you cannot bill out that rate. So we don't feel like we can get a very good source from Medicare. Medicaid is our primary source of income. Because we are a 638 tribe, we do get the higher federal rate, and that basically helps us maintain this facility. We do work with hospice in the local border towns. That there is a need for it, although we do run into issues because hospice billing, the way their corporations work, are a long ways out, and so sometimes it tends to be a problem collecting several months later. We do not get any tribal subsidies. And we do have a few people on a rare occasion that have private insurance or private pay. We try to be very, very careful with that because we have found people who will travel nursing home to nursing home who really the family doesn't intend to give the money, but they get their elder placed and then they go far, far away with the money. So we try to investigate very thoroughly before we consider a private insurance or private pay, but we do have a few people in our facility right now that are in that situation, and they are successfully doing so.
Okay. All right. Okay, that's excellent information. Thank you. And we're going to end this section with Ron Ross, and I believe Ron has some very specific information to share. So, Ron, you let me know when you're ready for that other slide. Thank you.
Thank you, Deb. So we'll just start with the slide that you're seeing right now, and we'll tell you that both of the facilities that we manage for the Okolala and the Rosebud are both just Medicaid facilities. They are not Medicare certified. Like Val said, if we were to become Medicare certified, we'd actually get less money than what we're getting for one of the facilities that we're managing on Medicaid. Tribal subsidies, when we first got involved with the Okolala folks, that was a mandate from them. They said, we'd love to have a nursing home, and we'd love to have a nursing home for our elders, but we can't afford it. And so if the tribe is going to have to subsidize the facility, then we can't move forward. And so they just said, no, they couldn't do it. when we got involved with the Rosebud folks, they had been subsidizing their facility to the tune of a little over $1 million a year, which was a lot of money for that tribe. So much so to the point that they were considering closing the facility. And, you know, they have 40 residents, give or take, and so that just didn't seem to make sense. But they were at a point where they just couldn't afford to continue to subsidize it at that rate. So now we'll go to the next slide, then.
All righty.
I want to start by saying CMS and the folks that work for CMS in tribal relations does a wonderful job for educating tribes to the opportunity to get an enhanced Medicaid rate. Everybody we have worked with at CMS at all levels have been very supportive of seeing that the Medicaid rate that the tribal facility gets is adequate in order to meet the needs of that facility. Now, there are some keys to it. And the first key is you got to have a state that is willing to understand that if they will amend their contract with CMS, called a state plan, and put in a state plan amendment, then they can actually work with CMS, and CMS will fund the Medicaid elders at 100% participation. Right now, the Medicaid program, the state puts in so much, and CMS puts in so much. If you're a fairly wealthy state, it's 50-50. If you're a poor state, it might be 70% federal dollars and 30% state dollars. But in Nebraska, it's about 50-50. But when the Oglala Sioux tribe said, hey, we want a new facility, and we can't subsidize it, I knew that the regular rate, like Rick was just telling you down in Arizona, is about $175 a day. I knew that was no way could that come close to paying the operating costs, labor, food, supplies, utilities, as well as the fixed costs, which would be depreciation and interest on a new building. And, that just, you couldn't do it. So there was no way to move forward, except CMS said, if you work with your state works with us, we will fund it 100%. Not only will the state not have to put money towards the Medicaid folks, we'll actually give you a higher rate so that you can make this happen. And so we gave you a screenshot to get over to the CMS website. It goes at length. The first step is your tribal council has to pass a resolution saying they actually want to add long-term services and supports to their 638 agreement with IHS, because that's a requirement. You've got to have an IHS 638 amendment to that agreement, adding long-term services and supports. We have found IHS to be very supportive in all the communities that we've worked with. Again, this is no money from IHS. All the money is CMS. And so they've been willing to add that service to the 638 agreement. And then when you communicate with the state that if you will put this on your state plan amendment, then CMS will pay 100%. And you take the Rosebud facility, when we got there, all of those residents that were on Medicaid, the state was paying their share of the cost. And now that the state has done the state plan amendment with the feds, and now the feds will pay 100%, they have actually saved the state of South Dakota hundreds of thousands of dollars a year, hundreds of thousands of dollars a year by adding this to their state plan. And we're in the process of negotiating with the state a higher rate. We are currently at about $220 a day, and we are working towards a rate of $260 a day, which would then allow us to increase our staff, as well as pay our staff better. But we are also negotiating with the state of South Dakota then to go to phase 3, which would be giving us a higher rate so that we could retire the debt, depreciation, and interest on a new building. Because if your operating costs are, $260, $300 a day, you need a higher rate in order to pay off the mortgage. And so we are in that process with South Dakota. In Nebraska, they took a different approach. Our legislature allowed tribal facilities not to have to go through the certificate of need process because they saw that the federal government was going to pay for it. So the legislature gave an exemption to tribal facilities so they don't have to go through the certificate of need. And once they found out that CMS was going to pay 100%, they worked a state plan amendment with CMS where we actually do a cost base. And so as long as the costs are reasonable and allowable, and you don't try to run something funny through the books, just pay what you're supposed to, that gets reimbursed by CMS. And right now our costs are a little over $400 a day for both the operating and the fixed costs. We've worked with, right now, Montana has negotiated a rate with CMS, and I believe they're at $429 a day. I know Val up in Alaska is a lot higher, but then their expenses are a lot higher. Tammy, I believe, in Wyoming, you've negotiated a rate somewhere around $329.
Yes.
And so it's all state specific. So, just work with your state, educate them that this is good for them because it will save them money, and yet it'll give you the facility a higher rate so we can take care of the folks and provide the services that we need to, and either eliminate or reduce the amount of tribal subsidy significantly.
Wow, that's excellent information. Thank you, Ron. I do want to mention that there is a file for download on financial sustainability with some of this information and also a little bit more, and that was provided to us by Lee Olitsky, a Unite member. So certainly feel free to download that. We're getting close to our Q&A time, but I just wanted to give all of our panelists a moment here to talk on these other considerations. Ron did touch a little bit on the role of the elder in supporting their family, but I'd like to also ask Ron, is there anything else, Ron, you want to say on that first point? I think you probably covered it in your conversation, but anything else you'd like to cover?
Well, I would just say, that the state folks, it might be new for them. Most of the states are not familiar with tribal situations. Their world is not tribes, and so when you start to talk to them about this is something new, but it's good, CMS is very supportive, and they have a lot of people that will help the state. And I think once you get them past being skeptical, then they get a lot easier to work with.
It's an excellent point. I'm going to ask Rick to talk briefly on the effective coding and billing, which comes up in tribal nursing homes, and the importance of that in terms of financial sustainability.
Thanks, Debbie. Before we dive into the coding and billing part, my first discussions with billing in the native area was in Cherokee Nation with a clinic, and billing and coding really starts with gathering data and information from your family and your customer, as far as Medicare numbers, Medicaid numbers, and benefits. And sometimes people just aren't used to giving that up. What Archie Hendricks has done here just recently, we've produced a kind of a guide for our families so they can read about it and understand why we bill and who we bill and how we bill. So we've gotten great feedback from our families about the instructions and guidance it provides them on the billing. But I think one thing I'd like to just make sure everybody understands is when it comes to billing and coding, there's no leeway. You've got to be 100% accurate, and U.S. government just doesn't give you any forgiveness in those areas. So if you get into nursing facility work, don't hesitate to reach out into a community of builders and coders in your area for that technical support. And in short, ask for help when it comes to building and coding. Thanks, Debbie.
Thank you, Rick. Excellent advice. And Val, did you want to talk briefly on the educating the community and tribal leadership and that importance to tribal sustainability?
Yeah, Debbie, thank you. I want to agree with what Ron said, that understanding the tribal leaderships and the board's role, and that they have other focuses in their world. So a lot of times what we as facilities have to do is educate them as to what happens in a nursing home and what it's all about. And a lot of times they don't know what it is. And education can take, like we did just recently, we brought our admissions coordinator over to discuss with them what the admission process is. Here in Alaska, it's different from the lower 48. And just to get someone here and Medicaid, it can actually take an average of 3 months because most referrals that we get have to do a Miller's Trust, and that's very different. For some of the elders, they can't find their birth certificates or ID, and they've never done anything like this before. And in many of the villages, we are the only nursing home within 50 to 100 miles, so they don't know what it looks like. The county or the borough we're in, if you will, is actually in the size of the state of Indiana, and for each of the villages, there's no roads that connect them. So they're all isolated, so we have to educate them as to the whole process of how do you increase admissions. A couple of years ago in 2015, we had no admissions. We had no discharges. Population was that stable. The next year we had 2, the next year we had 4, and then it's 8. So that process is now beginning as our population gets older. So bringing the board along with this in terms of what it means to admit somebody, and we'll go through that. What the state of Alaska requires, the whole pass-out part. And one of the things that they're looking at doing now is in each of the villages, we're working to have somebody there as a representative to do that education process. So that is, I think, very important just to bring them along.
Thank you very much. And Tammy, did you want to comment briefly on the role of the elder in supporting their family? I think someone touched on that briefly. I think Ron might have.
Certainly. I think it's a huge problem in Indian country that we have elders who are needing to support their families, and so that Social Security check does go to lights and food and utilities, and they're in very desperate need of a nursing home and for the nursing home care, but they don't want to give up that Social Security that CMS requires. And so that becomes a problem of meeting the Medicaid requirements, and yet they want to, of course, take care of their family. And so if we can ever figure out how to bridge that gap, it would certainly be a good thing for everybody involved. I don't have the magic answer, but we do have a lot of elders that struggle over it, and so it's a daily issue for us.
Yeah, supporting that. Okay. Thank you very much, Tammy, for sharing that. So at this point, I'd like to turn the conversation back to Julie for any questions and answers. Actually, I take that back. Sorry. We're going to talk briefly. I'm going to give each of the panelists just a minute or so to talk about how tribal nursing homes integrate in long-term support service, just kind of how they see that overall occurring. And I'll go ahead and call on Val Creel.
Okay, thank you, Debbie. Here up in this part of the world, we are part of the continuum of medical care, and that we don't have the complete set of medical care here in this area, and that's one thing that the organization is looking at. For example, there's no home health here, there's no hospice here, there's no assisted living here, so we are a very important piece of the medical system, but sometimes people think that we can also do things that we can't. And we've had referrals where somebody said, my heater doesn't work, can I stay with you until my heater works? So we do educate, but in terms of fitting in Salongport's service, we're very much an integral part here in the future. Our association hopes to get the other pieces in place so that we can have all the needs met for all the elders here in this area.
All right, thank you. And Rick, did you want to make a comment on that?
At Archie, we're moving into researching the ability to implement a Medicare home health agency and also a hospice agency. And as you've heard a little bit about the word census, to really get to the self-sustaining ability of an organization, that's really what we're studying here at Archie, to see that we would have enough business, so to speak, to support those operations. There are other things in long-term services supports also that a facility like ours could do that we may explore for the community. And one of those things is produce flash frozen meals prepared through the autumn traditional way that could go to homes, and elders in their homes could maybe use microwaves or what have you to warm those meals up. Those are just ideas at this time that they're exploring for the Archie Hendricks nursing facility.
That's excellent. Thank you. And Tammy, did you want to comment?
This is Ron.
Yeah.
I can jump in if you don't.
Okay, yeah, go ahead, Ron. That's fine.
I would just say that it's evolving. Nursing homes and the role that they're going to play in the future is going to be different for each tribe. Some, you'll have the management skills necessary at the nursing home to help reach out, maybe do some home and community-based services to do that. There might be other tribes that are more territorial. Department directors might be territorial with one another. And so it's going to be just a little bit more specific to each tribe. But nursing homes are certainly going to continue to evolve as we all age.
Okay, that's an excellent comment. Okay, thank you all for your comments on that last slide. And Julie, I'm going to turn it back to you for any questions and answers.
Okay, great. Thank you, Debbie. So this is our time for questions for our panelists. If you have a question for one of our panelists, if you could go ahead and please enter your questions in the Q&A pod located at the bottom right side of your screen. So we already have a couple of questions in the queue. The first one is, and this is regarding Social Security, and the question is, do residents get to keep a minimum dollar amount of their monthly Social Security payment, or does all of it go towards supporting their care at a facility? I wasn't sure if any of the panelists could speak to that.
This is Ron. Yes, I certainly can. In Nebraska, the resident gets to keep $60, and the rest goes towards their share of costs. So if they get $1,000 a month in Social Security, $940 goes towards their care, and they keep $60. If they get $2,000 a month in Social Security, $1,940 goes to their care, and they still only get to keep $60. So most states have an amount, and it's usually $50 or $60.
In Wyoming, we are at 50.
Here in Alaska, we're at 200. I'm sorry.
That's fine. It looks like we're the cheapskates. In Arizona, we allow our residents to keep $30 per month.
Okay, great. Thank you for responding to that. So our next question is about population size. So this individual, their community's population is relatively small, and so the potential residents for build a nursing facility or for long-term care the population size would be small. So he's wondering if there is a minimum size or population of residents for a long-term care facility to be feasible. Similarly, are there any models and successful programs that combine long-term care and skilled nursing facilities with home health?
Well, home health would be a totally different topic to talk about when you're talking about the nursing home. And the size, you're probably talking 20, 30 people minimum. Again, it depends on the rate that you're able to negotiate. We haven't talked about assisted living today, but I know that the Indian Healthcare Improvement Act of 2010 has some language in there so that tribes could take a look at that. There's opportunities with that piece of legislation to enhance Medicaid in different areas. So the health director of the tribes would want to learn about that.
Okay, and another question that has come through is, to participate in Medicaid through CMS, does the nursing home have to be on tribal trust land?
I would. This is Ron again. I would say that the answer to that is no, but there are some hoops to jump through in order for that to happen. And the Rosebud tribe bought a nursing home from private people years ago, and so it is a tribally owned, operated nursing home, so they meet the qualifications. But I would say most tribal facilities are going to be on trust land. That they absolutely, positively don't have to be.
Okay, and another question has come through that was directed for you, Ron. What are the ages in nursing homes and Medicaid-only funding in South Dakota and Nebraska?
We do find that our elders in our tribal facilities are, on the whole, a little younger than, say, a non-tribal nursing home. We have folks that are probably in their 50s, which I don't consider elderly. So quite a few of our residents are younger, 50s, 60s. Most nursing homes anymore are probably 80s and 90s. So we do have younger residents, but age isn't the deciding factor. It's whether or not they qualify for Medicaid, and in order to qualify for Medicaid, it's two parts. First part is it has to be medically necessary. You have to be frail, And then the second part is resources. You can't have CDs, money, bunch of land, things like that. Your resources have to be very minimal. Nebraska, it's $4,000.
Okay, and you kind of yes.
Jules, can I make a comment on that? This is Tammy. We have seen people leaving our nursing home as young as 30, and the reason being is alcoholism and the meth abuse.
We've seen that in the Autumn tribe also.
Okay, great. Thank you for adding that bit of information as well. That's very useful to know. So another question that came in is touches on assisted living, and this audience member has asked, is there a difference in billing in regards to assisted living versus nursing homes?
This is Ron. There is. Again, I think there is some more communication that needs to be done with CMS, and to talk about assisted living. Obviously, the cost of running an assisted living facility is a lot less than a nursing home. And there is opportunity through the Indian Healthcare Improvement Act to improve upon assisted living. And basically what we're talking about is folks that need help with activities of daily living, bathing, toileting, dressing, rather than skilled care. So those are things that the tribe would need to explore more with CMS and their state.
Okay. So we have another question that was briefly talked about during the presentation itself, but I'm hoping we can just reiterate that here since it seems to be of some importance for the audience members. So for this particular person, they have had elders interested in a tribal nursing home until they learn they have to turn over their Social Security. Then the potential residence indicates their family has to use the check to live on. Can our panelists address how you worked around this for some of maybe your residents?
I don't know that there's a way to work around it if the tribe is not willing to subsidize that portion of the amount that's not going to be collected. Our two tribes that we work with, the tribe said that they were not willing to subsidize in order for the resident to keep their share of cost. And so it's a condition of admission. If you want to be admitted, you'll do that. But other tribes who might have, good casino revenues or something, they might decide that they're willing to do that. I guess it would be up to each tribe.
Julie, this is Tammy. I might add to that because we've had this case scenario happen. If the individual continues to let their family keep the Social Security check, Medicaid will eventually discontinue their benefits. So then they will have nothing.
Okay. All right. Well, thank you for those responses to that question. Another one has come up about assisted living versus a skilled nursing facility. Could assisted living and a skilled nursing facility be combined in one facility feasibly? Or can we talk about how oftentimes of an assisted living facility will transition into a skilled nursing home? Can any of our panelists speak to this?
This is Ron. I would say that it is. One of the things that you need to be aware of is because of the sovereign nation of the tribes and their building codes, you have certain flexibility. However, if you're going to collect Medicaid dollars, then my experience is those buildings need to be built with the regulations in mind. And so there can be different regulations for the construction of an assisted living versus skilled, like how fireproof the walls are, and things like that. So you'd want to make sure how the construction either is or is going to be done. Quite a few of the facilities that we're involved with have a area for assisted living and an area for skilled, and perhaps they share the same kitchen. The staff normally don't mingle. You usually just have one staff for one and one staff for the other, but there are some economies of scale to think about if you were going to have an assisted living and a skilled nursing home on the same campus.
Okay, and do any of our other panelists have anything to add to that question?
Just as a point of note, I was recently in the state of North Carolina, and I ran into several skilled facilities there constructed in such a way that the assisted living portion of the skilled building was in the same building. So as Ron said, if you follow the codes, you can definitely build a building that meets the criteria for both services. It's just designating which beds are skilled and which beds are assisted living.
This is Val from Alaska, and you, like what you just heard, that I worked in South Carolina. I was actually administrator for a duly licensed facility, and you can do that. The main thing you want to do is have some sort of separation between the assisted living and the skilled nursing, so that they feel like that's their home, because they do like a little bit of that separation.
Okay, great. Well, thank you all for responding to the questions that came in from our audience members. I feel like we had a very fruitful dialogue there, and that was really great. So we're going to go ahead and move forward with our presentation, and Debbie is just going to leave us with some closing remarks.
So thank you all for being on today's call. Again, our collaborative is the Uniting Nursing Homes and Tribal Excellence. We are also open to tribal assisted living facilities. And so we encourage you to reach out to me as a contact or to Tammy. We co-lead currently the Unite Collaborative, and we'd love to talk to you about that. All of our presenters today, I think, were very willing and encourage you to seek help and to talk to them in your journey in this area. So thank you all.
All right, thank you, Debbie. And so there is the contact information for each of our panelists if you would like to reach out to them directly with any other questions that may not have gotten covered during today's presentation. In closing, I'd like to thank all of our panelists for joining us today and for sharing their knowledge, information, and experience about tribal nursing homes. In closing, I would like to remind everyone that today's webinar was recorded and that the audio and PowerPoint will be made available online at cms.gov on the LTSS Technical Assistance Center website. Thank you again for joining today's webinar. Our session is now concluded.